Ready to roll? Good afternoon, everyone, and welcome to our September quarterly meeting of the Kentucky Judicial Commission on Mental Health. I'm Deborah Lambert, the chair, and so good to see everyone. It seems like it's been longer than 3 months since we've gathered. We have officially made it to our 2-year anniversary mark. For those of you who are attending the meeting via Zoom, you have missed the opportunity to have Smurf teeth. We have several of us are walking around with blue teeth from eating the delicious cake that Shauna was kind enough to purchase for us. No state funds were used. So thank you, Shauna, for cake. It always goes over well, even with the blue teeth. So let's talk a little bit about, in an introduction, all the things that you all have accomplished during this recent time period, at least. We have completed statewide mapping of the criminal justice, juvenile justice, and child welfare systems, and we're extremely proud of that. Of course, we hosted that groundbreaking mental health summit. We've completed a listening tour offering town halls across the state. And not to be forgotten, we passed our first legislative package unanimously. It will never happen again. And we're now offering community mapping opportunities for the judges and partners throughout the state. And that doesn't really even scratch the surface of all the things that are happening in our work groups. I'm so proud of the many work groups that are working to truly break down some barriers. And thank each of you for your continued commitment to work on the Kentucky Judicial Commission on Mental Health. You know that our order of appointment was for a 2-year period of time and was set to expire on September 1st. Shauna reached out to each of the commission members, and we've done a little bit of modification of that. So I want to thank our resigning members who have been crucial and very critical to our work. Justice Denise Clayton, who's the retired Chief Judge of the Kentucky Court of Appeals, is retiring from the commission. Stacy Bruner, immediate past president of the Kentucky Association of Circuit Court Clerks. Jim Daly, the immediate past president of the Kentucky Jailers Association. Joe Ross, Logan County Attorney, and who was representing the Kentucky County Attorneys Association. Sarah Johnson has resigned from the commission under her position with the Department of Corrections, but you'll see her here today serving as a delegate for Commissioner Katie Marks. Sarah, we're happy to have you remain with us in this work and hope you're enjoying your transition to the Department of Behavioral Health. Katie Comstock, Boo, our our AOC director, has announced that her last day with AOC will be September 20th, a dark day here in this building for sure. Katie, we're so grateful for you and your leadership and working with the commission and the executive committee, and we'll miss you and hope that you have a wonderful tenure at the LRC. Now, for new members, we have Margaret Forsey, who is the Owen County Circuit Court Clerk, Margaret, and president of the Kentucky Association of Circuit Court Clerks, and Jordan Dallas Turner, Boone County Attorney, yay, and representing the Kentucky County Attorneys Association. Josh Lindblom, is Josh here? I've left my glasses in the car that aren't sunglasses and I can't read at a distance. So somebody will have to tell me if Josh is here. He's the Hardin County Jailer and president of the Kentucky Jailers Association. Shane Stevens, Harrison County Sheriff, has been with us before, but now officially listed on the order as president of the Kentucky Sheriff's Association. Randy White, who's commissioner for the Department of Juvenile Justice. Cookie Cruz, is with us as the Commissioner of the Kentucky Department of Corrections. Jonathan Shell, Commissioner of the Kentucky Department of Agriculture. Kelly Foster, Associate Commissioner, Kentucky Department of Education. Matthew Cole, Commissioner of the Department of Vehicle Registration in the Kentucky Transportation Cabinet. And Thomas Stevens, I happen to know where he's sitting over to my right, President and CEO of the Kentucky Association of Health Plans. So we are grateful to each of you for your willingness to join us at the forefront of Kentucky's work in addressing mental illness, substance use disorder, and intellectual and developmental disabilities where they intersect with the judicial system. I certainly hope that you'll find this work both rewarding and complementary to your agencies and other work. A copy of the new Supreme Court order is included with your meeting materials. And also in your meeting materials, you'll find updated commission work group structure. That's hard to say. Updated commission work group structure that will now reflect Steve Shannon as the Executive Director for the Kentucky Association of Regional Programs as the lead for the pre-arrest and diversion work group. Steve couldn't be with us here today, but I do want to thank him for his willingness to take on this project. He's been actively participating in the majority of the work groups and has a well-rounded vision of what everyone is working on. He sends his regrets, but is grateful for the opportunity to lead in this regard. Additionally, Chris Griffith, the program manager of the Family Life Counseling Program with Christian Appellation Project, will be backing up Judge Cutoff as vice chair of the Civil and Family Justice Committee. And like Steve, Chris participates in multiple work groups and has been a strong member of the 3 work groups under the Civil and Family Justice Division. Thank you, Chris, for stepping up. I'm going to talk briefly about community mapping. Over the past quarter, the commission had the opportunity to participate and partner with the Kentucky Court of Justice as they hosted the Recovery Oriented System of Care Summit, or ROSC, as it's called, in each of the 7 Supreme Court districts. We shared with them the town hall report, and they were able to provide educational sessions that look specifically at issues we're also concerned about: cognitive impairment in the courts, including an overview of acquired brain injuries, the power of trauma-informed approaches in a court setting, and person-centered approaches and harm reduction efforts. And there was also, of course, perspectives from the field panel about best practices general or regionally. The commission was also invited to share at each event about how we've tried to optimize connections and collaborations and how that's helped us to establish the commission. We invited judges at each of the events to sign up and participate in this newest initiative we have going, the community mapping projects. And we are very grateful to the National Center for State Courts and Judge Vanover in Pulaski, Lincoln, and Rockcastle for his willingness to serve as our pilot site. And by doing all this, we're taking the commission's efforts to all of our communities. And based on our statewide mapping of all 3 systems, we've created a framework that will pull together court partners over a 2-day event, is the way the project is designed, and it will have the participants identify gaps and in their region and brainstorm opportunities on how they can improve. It will incorporate, these community mapping sessions will incorporate sequential intercept model for the criminal justice system and upstream for the child welfare and juvenile justice systems. But because those 2 concepts are kind of merging, you won't hear much about them separately during the project, but because we're trying to create an event that maps all 3 systems at the same time. Our behavioral health liaison, Jennifer Van Ort Hazard, will lead this initiative with staff from AOC's Statewide Programs Office and they will be assisting trained facilitators. I want to thank Debbie Hall of the director of the statewide programs office for allowing us to share the commission's work at those summits and providing staff, not only for the community mapping event for all commission, but for all commission activities. We truly couldn't do this without their help. The last recovery-oriented system of care summit was held just 2 days ago here at AOC, and we are now completely booked for mapping events through 2025. Those sites include Warren County, Johnson County, Madison and Clark, McLean and Muhlenberg, Scott, Bourbon and Woodford, Union, Crittenden and Webster, Bullitt, Hopkins, Henderson, Jessamine, Garrett and Lincoln, and Barron and Metcalf and Hardin County. So just because they claim to be booked at doing that doesn't mean you can't sign up now and maybe get in before 2025. We'll see. Community mapping requires a judge or judges to be willing to take the lead. So if you're a judge here today and want to be on the list, just let us know or our staff know. And we'll keep you all updated at these meetings on how that is going. Let's talk a moment about Seth's Law. I know Dr. Slusher will provide some additional updates on Seth's Law in her report today, but I wanted to take a moment and share that we put together 2 videos highlighting House Bill 385. Both are available on our webpage, the court webpage, as well as an overview of the efforts. I encourage you to share those videos widely to assist in educating those impacted by this legislative change. As soon as the legislative session ended, we started talking about what we could do next. We were a little bit high, supposedly, from the unanimous vote from both houses, I guess. But obviously, we all know that this is not a budget year, so we're looking at various legislative initiatives that could be or need to be proposed, and the executive committee will be making some considerations in the next few weeks to see what we might best approach. So please take a look at the legislative recommendations that are included in your packet. And if you or your agency has comments, concerns, or feedback on those recommendations, speak now, please. Or at least send those to directly to Maria. She is heading that part of the work. The executive committee will take a final vote during our October meeting. So if you have anything that you need to share or even new suggestions that you might want to make, please do so by October 1st. And I know I'm excited about the presentations that we're going to have today. First, I'd like to welcome Angela Sparrow. Angela is the Behavioral Health Supervisor with the Department of Medicaid Services, and she will share with us about their judicial initiatives, specifically looking at the reentry demonstration that we have supported since we learned about those critical efforts at the Mental Health Summit. Angela?
Thank you. Test. Okay. I think we're right. Thank you. All right. Again, Angela Sparrow, I'm one of the behavioral health supervisors in the Department for Medicaid Services, and certainly appreciate the opportunity today to discuss some of the behavioral health initiatives specifically within Medicaid, and then again, specifically regarding our judicial initiatives and systems in Medicaid. There. Thank you. And also, again, before we do that, just want to provide a little bit of history about behavioral health services within Medicaid. So again, Medicaid did expand in 2014 as a part of the Affordable Care Act to cover behavioral health services at that time. So again, it is still somewhat new within Medicaid in terms of coverage of behavioral health services. we have over the years, again, expanded significantly to cover additional services. And certainly, again, the projects that we talk about today and those initiatives will continue to do so even more so in the years to come. But again, when we do talk about behavioral health services and Medicaid, this is including mental health and substance use disorder services. And so again, our managed care organizations and partners, again, our MCOs, they are also required to cover the state plan covered services within Medicaid. They also, again, provide value added services in addition to what Medicaid, again, does cover. They also, again, provide care management programs to support, again, those additional needs for those individuals. So again, our managed care partners do work with us and we work with them in terms of covering and providing behavioral health services in this space. But again, they do provide additional services and can do that. So we do provide a full continuum of services for behavioral health from inpatient. We also, again, provide SUD, substance use disorder, residential treatment. We do not currently do that for mental health in terms of residential, but that, again, is forthcoming in some of the future initiatives as well. And then again, a full array of outpatient services, intensive outpatient programming, group therapy, individual therapy, day treatment. So again, full array of services in addition to supportive services. Many of you all probably heard of peer support services, targeted case management. So again, those supportive services are accompanying with the behavioral health treatment services that individual is receiving. But as we move forward in expanding services, again, our supportive services and array continues to grow, and some of that we'll cover today. But really, again, the benefits of those supportive services to help engage individuals into treatment, to help them maintain treatment and long-term recovery and supports is again critical. So I do want to talk a little bit about the Section 1115 demonstration. You may or may not have heard. Again, 1115 is mentioned a lot in Medicaid and across the state these days. And so we do have a Team Kentucky 1115. It is a very broad 1115 demonstration. So 1115 demonstration opportunities and projects allow state Medicaid agencies the authority to operate outside of what Center for Medicare and Medicaid Services, so Medicaid state authority, not state authority, federal authority, again, regulate the Medicaid agency. CMS provides opportunities to states to demonstrate, pilot new services, again, innovative approaches to delivering services outside of, again, what is typically allowed. And so through these demonstrations, again, the states, CMS does approve states to do so. And I wanted to review, there are several demonstrations within Kentucky. So when we talk about 1115, there are lots of different demonstration projects occurring and will be occurring over the next year to 5 years. But again, specifically around the reentry demonstration, Kentucky was approved in July of this year for our reentry to move forward in our reentry demonstration. So some of you all, again, may have been aware that Kentucky did submit for an application to CMS in 2020. And so since then, again, during that time, Kentucky was the first to do so in a demonstration opportunity like this. And CMS, again, did not have that guidance developed for states in order to carry out these opportunities. So they did develop guidance for states in what a demonstration would look like. Again, really kind of setting those goals and milestones that the state would be required to meet. And again, they want to streamline some of the demonstration aspects across all states, but also, again, allow states to be able to implement and how it is going to best benefit their Medicaid programs, their beneficiaries within their state. So again, that is individualized. And the focus, again, if if you're not aware, prior to this opportunity, again, state Medicaid agencies were not and have not been able to reimburse for any Medicaid services while an individual is incarcerated, or again, while a youth is placed. And so this is the first of the kind to allow state Medicaid agencies to reimburse for selected services while an individual is incarcerated. And again, the reminder there is it is a selected benefit package. It is not full state plan Medicaid benefits while that individual is released. And it's also, again, not during the full course of their incarceration period. So it is a set time period as well. And so again, the emphasis really is on that pre-release, that coordination, collaboration among our judicial systems, our healthcare systems, and our community partners to really support that individual as they are nearing that reentry period. And again, ensuring that we're providing that continuity of care, both right healthcare and those health-related social needs, really addressing what are those employment, housing, food insecurities, those are the, again, holistic services that that individual needs at the time that they're released. So really, again, the emphasis and focus of the demonstration is that collaboration with our systems to ensure that we're supporting them collectively together through that period. And again, long-term, those long-term supports after they reenter the communities. And also, again, so with the approval of the demonstration, CMS did, make it clear to states that this demonstration is not to supplant the work that our judicial partners are already doing. But again, this is really fostering that collaboration, that coordination among our systems, and again, how to support that individual through that transition period. And this, again, in order to do that, there's also a large emphasis on health data exchange of between systems that right now, again, typically is siloed. There is very limited exchange in terms of information of that individual from that time that they're incarcerated and into the community. We know that that creates barriers in terms of being able to provide that continuity of care, that ongoing care. So really the emphasis again on looking at what our systems are in terms of IT systems and that health data exchange network, and how can we again coordinate, interface with systems to also from that perspective in terms of IT and so forth, be able to also support that continuity of coverage. The demonstration again also wants to ensure that all individuals at the time that they are incarcerated have that opportunity and afforded that opportunity to apply for Medicaid if they do not currently have Medicaid. So we want to ensure that at the time that that individual is incarcerated, that we are screening for Medicaid eligibility, determining what that Medicaid eligibility is, and suspending those benefits appropriately so that at that pre-release transitional mark, we can then reinstate those benefits before that individual is returning to the community. And again, therefore, we are providing that continuity of care, ensuring that at the time that they are released into the community, that they do have access to that healthcare coverage through Medicaid. So Kentucky, again, is already suspending benefits at the time that an individual is incarcerated or our youth is placed. But there are certainly some barriers and challenges to that. So again, this demonstration offers an opportunity. A lot of that is still a very manual process. It is very time consuming if it's a manual process. So those are things that under the demonstration we're able to enhance, develop, and again, ensure that we're doing streamlined approach to these processes moving forward. So again, the service package, to talk a little bit about that, it does include case management service, and it's intended to be a comprehensive case management service that's really screening, but prior to the individual being released, screening for all medical needs, behavioral health needs, and those health-related social needs that we talked about. So what Where is that individual residing at the time of release? What is, again, their employment, job opportunities? How are they going to get to that? What are their behavioral health appointments? And so again, identifying what all of those needs are for that individual prior to them leaving, working with our correctional partners who are already providing some of those services and supports, again, to enhance that. But this is now a service that can be reimbursed by Medicaid and provided by Medicaid. And so again, developing that plan for that individual to meet those needs, both pre-release and then again, carrying forward what that plan looks like for them at the time that they are released. So case management is one of those services. And then medication-assisted treatment is another covered service. And again, medication-assisted treatment is specifically for individuals with substance use disorder. That does include medication for that individual, as well as the company therapies, again, to treat the SUD. So those services, case management and MAT, medication-assisted treatment, they are eligible for those services 60 days pre-release. So again, we want to engage with that individual, an opportunity for Medicaid to reinstate those selected benefits, engage with that individual, the health plan, again, MCO, engage with that individual through that pre-release period, build rapport with that individual, develop that plan to carry forward. And then also the benefit package includes a 30-day supply of medication, all medication for that individual at the time that they're released. So ensuring that they are leaving, walking into the community, as there's some limitations in that as well, that we'll work through. But again, ensuring that they have those medications that they need at the time that they leave. Some of those things, again, as clinically appropriate, some medications are not going to be appropriate for them to leave with a 30-day supply. So those, again, those things we'll work through as we implement. I should have also led with and started the population that is covered within the demonstration is for our adults in our state prisons and for our youth in our youth development centers. So those are, and again, those are the covered populations under the demonstration that are eligible for those services 60 days pre-release. So it is, again, we are looking at it. It is based on facilities. And so those correctional facilities that are covered in the demonstration, they are required. Those correctional facilities are state prisons, are YDCs. They are required. Again, they will be working with Medicaid. We have to ensure that they are ready to provide these services, that they have the capacity to provide these services. And again, that our systems are set up to coordinate, talk to one another. So again, all of those things have to be in place before we can implement and begin the demonstration. And there is an opportunity, again, services can be provided when we're talking about the pre-release services. They can be provided via telehealth or in person. And again, can be a combination of in order to support the population, ensure that we can meet them where they are and be able to provide those services. And again, the initial approval does not include our county jails. And there again are various reasons for that. Certainly, we see the opportunity and do want to expand in the future to include that. We know that there is certainly a need for that. But when we are looking at the requirements of the demonstration, being able, again, to ensure that we have the infrastructure to onboard our county jails. There are several jails. Again, each county is operating can operate very differently. We have to ensure that we are able to meet the requirements in terms of services delivered to those individuals at the appropriate time frame. And so again, this does allow us to be able to implement, really build that infrastructure, be able to expand and grow as we move forward. I know that's a lot of information.
Are there any questions of Angela regarding this new initiative?
Yeah, I do want to mention that also many of you may also hear about the Consolidations Appropriations Act. And so this again is corresponding with the Reentry 1115 demonstration. So in 2023, again, Congress did pass the CAA Consolidations Appropriations Act. This is also a mandate to state Medicaid. So the reentry demonstration is optional for states. The CAA is a mandate to state Medicaid agencies. And so Medicaid is required to cover selected services as well, pre-release. And so what we are looking at, again, CMS did just release the full guidance to states July of this year. So we also are required to this section, again, and mandate does take effect January 1st of 2025. So that is quickly approaching. But really, we think again, in terms of Kentucky having our approval for our reentry demonstration, Medicaid will meet many of the requirements of CAA through implementation of our reentry demonstration. Do want to highlight a couple of things about CAA briefly that we will be working through in planning moving forward. So just to kind of keep in mind, when you do hear CAA and those requirements, we are talking about adjudicated juveniles. And again, the act does define an eligible juvenile as an individual who is under 21 years of age, or again, between 18 and 26 that are former foster care youth. And so for that eligible population, that eligible juvenile, states are required to cover the EPSDT services, early periodic screening, diagnostic, and treatment services. So this does include screenings for behavioral health needs, dental needs even, in the diagnostic services for that. So states are required to provide those services for this population. And again, it is 30 days pre-release. And targeted case management services, very similar that we talked through about the reentry case management service, targeted case management services, 30 days pre-release. So again, as we are moving forward with the reentry demonstration planning, we are also moving forward with how is Kentucky going to meet the CAA requirements. And that again is being incorporated within our implementation planning. But one thing to note, based on the definition of an eligible juvenile, we again are looking at the settings in which an eligible juvenile would be placed in. And so that does include our local prisons. And again, I think in conversation with DJJ also learned it can also be, we can have some youth, again, adjudicated youth in our youth detention centers as well. So if you haven't, some of you probably will be hearing from us very soon as we look at how we are going to meet the CAA requirements. And especially again, for our jail population that was not included in our reentry demonstration. So for our youth development centers and for our state prisons, through the reentry planning, we feel like we again can meet the CAA requirements, but we certainly again have some planning to do with our local jails around these requirements and provisions that are to take effect early of 2025. So also, again, just want to let you know that although the provisions do take effect January 1st, 2025, Medicaid agencies can submit to CMS within that first quarter of January 2025. So we do have a little bit of time there. But again, if you haven't heard from us, expect to hear from us very soon in terms of engaging with our local jails, our Jailers Association, our counties association regarding the CAA requirements and steps.
Had a question. This is awesome. Is there a veteran component to this initial piece?
Yes, and I'm glad you said that. So again, just kind of briefly in some of the work that we've done thus far in next steps in terms of reentry in 1115, we have done again some significant stakeholder engagement and hearing from agencies, individuals with lived experience, our managed care partners, and so forth. So really developing what is the current state in terms of reentry services across Kentucky. And then that again is helping us also identify right where our gaps and our barriers are. And within that, there are some of those specific subpopulations, if you will, that we have looked at and identified. So veterans being one of those. So we have engaged with VA and our Kentucky Department for Veterans in that as well, kind of again mapping the current state, but also we learned some great information that they already have great connections with DOC and that there again are case management services already occurring for those. So yes, we will also then work with them to say, how does this program support the work that's already being done? And then how can we coordinate those for those individuals that again could be Medicaid eligible, but also have VA benefits. And so that will be part of it. And so, yes, there are some of those subpopulations again that again, we are looking at. Do want to note, so we do have an implementation plan due to CMS the end of October. Because we did receive approval does not mean that we're able to start implementing today, does not mean that the services are in place today. And that again, you know, our correctional facilities can begin providing these services, billing for these services. So we do have to submit a plan to CMS. It does, again, they do have to review the information. There's, you know, discussions, negotiations that occur before the state again can implement. So upon approval of that implementation plan, we can begin those system changes, implementing the policies and again, procedures in order to implement. So for timeline wise of implementation of the reentry demonstration, again, we're looking at July to even October of next year.
So Angela, thank you for that presentation. That was very helpful. Can you tell us how long this demonstration will extend? How long will Kentucky be authorized to provide these services under the demonstration? And also, I'm wondering if it's possible to get this slide deck in a little bigger print because my eyes can't read most of it. Okay, great. Yeah. Thank
We
you.
can, yes. So the approval is for 5 years under the initial demonstration, but again, states typically will request extensions moving forward. So very similar to our SUD 1115 demonstration extension, but states have the opportunity to also submit an amendment at any point in time to your demonstration. So we can, you know, request to add additional settings and services as we grow and move. And so again, that's certainly an option for states and for Kentucky. Yeah. I know I know we are out of time, but we will certainly share the slide deck with you all. Just wanted to highlight part of also that will impact our judicial population is the Recovery Resident Support Service. It was requested with the 1150 with the reentry demonstration. It is not approved with the reentry demonstration because it is not a pre-release service. But Recovery Resident Support Service, it is again, through Senate Bill 90, Medicaid was tasked, you know, to meet a couple of the deliverables in terms of developing a mechanism to reimburse for recovery housing. Medicaid cannot reimburse for housing, and we do not reimburse for recovery housing. So again, we are looking at in the lens of how can we reimburse for the services provided in a recovery housing, and the importance of those supportive services in recovery housing. So the RRSS service, again, is a service in which recovery housing programs, recovery residents can provide and be reimbursed for. So it's not the housing itself. But we worked with our state partners, Department for Behavioral Health, again, to develop the RRSS service, really setting some of those standards in what that service would look like for our recovery residents. And again, some of those requirements in order to provide that. So we do have that request pending with CMS. Expect approval of this service under our SUD 1115 demonstration come this fall. But the service will be eligible for our Senate Bill 90 participants and our the individuals that are in our reentry demonstration. So we are starting with just those populations that would be eligible for RRSS, really developing that service before we expand broadly to the whole SUD population within Medicaid. So more to come on that. And then we'll share again just the pilot here, the multisystemic therapy pilot again is for our youth. It's more of a support diversion, if you will, for youth that are at risk of again entering the justice system. But this is an ongoing pilot. It's been a small pilot with just a few providers across the state. So we're continuing to monitor that. But just wanted to share, please reach out if you have any questions about the demonstration and would like to speak further. We're happy to do that. And then so this mailbox again is monitored by the behavioral health team within Medicaid. So again, please feel free to do that.
Thank you, Angela,
You're
very
welcome.
much for that presentation. I'm so excited that we do have this opportunity in Kentucky. And I know that was a lot of extra work for you all to get the approval, and we're all grateful for it.
Thank you.
Thank
And I
you.
will say it is a state, it is a Kentucky effort and lots of work again for our partners. So thank you all who have been involved in that. It is certainly not Medicaid. And again, while we may have the authority to be able to implement the program, we certainly can't do that without you all. So thank you.
Thank you. We have just a brief presentation via Zoom on a happy circumstance. Tom Vicini from Operation Unite has been working hard with his team to have some youth rallies throughout the state. And we heard about it and we're so excited. We wanted to kind of do something off our regular agenda. And here's some good news. So not that we have bad news here today, but some extra good news. Tom, would you please?
I would. Thank you. Thank you for the opportunity. We're taking a week off or 2 weeks off from our regular prevention programming in the schools to do a couple, well, actually 7 youth rallies that have, today was, well, it was supposed to be number 4. It's actually number 3 because of the shooting incident in the Corbin, London area. We had to cancel the one or reschedule the one that was set up for the Corbin Center. We had 1,200 sixth graders registered for that event. So we're trying to set it up hopefully sometime next week or the week after. But we've had 3. We had one in Harlan County and we had 444 sixth graders. And then we were at the Mountain Art Center in Prestonsburg yesterday, had 777 sixth graders. And then today we're Pike Central and have a little over 500. We'll be in Moorhead Monday, Somerset Tuesday, and Hazard Wednesday doing these youth rallies. And it's very difficult to have that many in 2 weeks, but it's also very rewarding. And what we do with the kids is, like I said, we're focusing on the sixth graders, and we picked them out because they're getting ready to go into a transitional stage in their life as they'll be entering middle school next year. So we want to give them some hope, instill some life skills and some information that they might need so that they can be effective in this next move in their life. And we start out and we give them a couple messages of hope. We start out with that. First of all, we get them excited. And if you've ever been in a room where 777 kids are screaming at the top of their lungs, please bring, earmuffs or something like that, because it's unbelievable how excited these kids get. So then we move from that. We have a gentleman, his name is Ty Sales, and he's from Youth to Youth International. And he gave a great message on the power of acceptability. Whole theme of that message was that basically kids need to understand that other kids that might not be like them, think like them, look like them, talk like them, that we have to learn to accept everybody. I think that would be a good message for us adults too. And it is a good message for this entire country, that people don't have to be like us and think like us in order for us to respect their opinion and treat them with kindness and empathy. So that message was really resounding to the kids, and you could see they were soaking up every moment of it. Then we tell them a whole lot about, they bring their family resource people with them and their teachers, obviously. So we give them a message about our Unite clubs, our anti-drug clubs in the school, about Camp Unite and how they can come to our free camp for a week every July. We give them messages about Shoot Hoops, Not Drugs basketball camps, and all the other prevention programming that we do, so that they can sign up with us. They can sign up with our people to come out and do these evidence-based programs in their schools. I guess we'll have more than 5,000 kids that we reach. In Moorhead, I think we're expecting about 1,000. 1,200 plus will be in Corbin when we do get that rescheduled. Somerset should be around 1,000. So we're really reaching these kids, and just like I said, we're trying to give them hope and let them know, the first message I give them is how valued they are in our eyes, and that no matter what they might be going through in their lives, that there are people like us that, all over the place that really care about what happens to them. So it's just been a blessing. I wish that you all could get out there. I can tell you how great it is, but unless you see it with your own eyes, it's really hard to take in, because these kids are just wonderful. And I think that's something that they really need. So I appreciate the opportunity to present this information. Of course, this is just one of many programs we do, but we look forward to this every September, and so that we can get into the schools with these kids.
Thank you, Tom, for that presentation. I know we could have had you present in December, but I knew your passion would be high right now in the middle of all these rallies. And
Right.
I may talk with you later to see if you'll write an excuse for me to be there next Tuesday at the
I would be
Somerset one.
glad
It is
to.
during court week. So, but I'd much rather be there with all those kids, I think.
I think you would really enjoy it.
And I love that age group, so that would be fun.
Mhm.
Next, we have a very important and insightful presentation, I'm sure, from our friends at Eastern State Hospital. We have with us today Dr. Lindsay Jasinski and Dr. Mark Woods, and we're so grateful to have you here with us to present about the Empath program that you all are using to improve behavioral health outcomes. So give us a rundown on that and all the good work you're doing. Thank you so much for being here.
Yeah, thank you so much for having us. Not sure if that's high enough, but we're gonna make it work. So yeah, thank you so much for having us. We're gonna kind of go through these slides as soon as they come up pretty quickly. We want to thank you for having us. Dr. Cooley couldn't be here today, so we do apologize on his behalf. And as many of you have heard, the Empath Center in Lexington has actually opened up July 30th. And so for many of you that have heard the pre-opening, sort of presentations. We're super excited to be able to tell you about all the really cool developments since it's open. So, yeah. Ah, perfect. There we go. So, what does stand for? Empath stands for Emergency Psychiatric Assessment for Treatment and Healing, and it's a concept that was developed in California back in the late 70s, early 80s by Dr. Scott Zeller. And so we've been working with Dr. Scott Zeller to sort of develop our own empath right here in the Bluegrass. And so this is the first of its kind in Kentucky. There are about 30 of them in the country. And so we're super excited to bring this brand new model. Yeah, I'd love it. All right. Absolutely. All right. There we go. So we're super excited to be able to bring this model to Kentucky, to Lexington, but we have zero interest in having several UK healthcare empath programs across the state, but we are super excited and happy and willing to help you bring them to your community and develop your own. So happy to do that. We're going to go through these slides pretty quick, just in the interest of time, and try to get through them. But again, you have the slides, and if you don't have the slides, of course, Shauna is always great about getting slides to us. So a couple things we want you to know right up front is that this is not an alternative to the ED. So at UK Healthcare, the way that we are approaching our Empath Center is it is the destination. It's not an alternative. It's where we want our patients that are experiencing any sort of crisis in behavioral health to go. We want them to come to the empath first, not the ED. We know that they'll still show up at the ED, and we've got processes that kind of get them to us, but this is the starting point for us. We also know that a lot of crisis stabilization sort of units or models fail often because there's too many exclusions. You can be too sick for them. You can maybe not be sick enough. You can be the wrong kind of sick. You've heard things like, we don't take this, we don't take that. And the empath model is like, you come to us, we sit down with you, we meet you where you are, and we begin to work on the things to help you get stabilized and hopefully not have to have you go to an inpatient unit. We want to keep you back out in the community, get you connected to services, get you the medications you may need, and then work from there. No exclusion. We talked about the other thing that makes us unique from EDs in an empath unit. When a patient goes to an emergency room is very loud. It's very chaotic. There's heart attacks. There's motor vehicle accidents. There's a lot of things that'll get prioritized way over a behavioral health crisis. And so oftentimes the patients that go to the emergency department will be kind of put into a room in the back, or even worse, put in the hallway, and they'll be prioritized down the line, and it will take a long time. There's lots of evidence that shows just how long it takes to get patients treated in our behavioral health patients treated in our emergency departments. And we know that that's where they show up. So when patients are in crisis, they either show up in the ED for the most part. Oftentimes they end up showing up in the jail, and I'm going to talk a little bit about the work that we've been doing with Judge Tackett as well. But again, we're trying to meet them where they are. We're trying to, the staff that's going to be interacting with them are trained psychiatric professionals. We have peer support specialists involved as well, so that they can share their lived experience with those individuals that are coming into us. Yeah, and it's just a more calming and healing, comfortable setting, than an ED is. So this is sort of the map of all of the different empaths across the country. We're not going to spend time on this. You'll notice very few. The ones in purple, we've changed the slides on me, and that's okay, Shauna, but the colors have changed. So the purple states are the states that actually have an empath center in them. And you'll see there's a lot out sort of west and really kind of the Central America, or the Midwest, we're getting a lot out there as well. Joint Commission, I will tell you that this is highly recognized as a Joint Commission standard. They are beginning to see this as best practice, and they have lots of publications on just that. Not going to spend a ton of time on this slide, but this is the slide that sort of is kind of the backbone of all empath centers. If you go to one empath center in a different state, it will look very different than the one we have in Fayette County. but there are some commonalities between all of them. And it's these 6 goals from, again, from Dr. Scott Zeller, excluded, rapidly stabilizing the acute crisis, avoiding coercion. A lot of things that sort of like outline how that empath unit should function. Again, you guys have these in your slide deck. Why now? Why Kentucky? Don't think I have to spend a lot of time on this. There's lots of data and statistics that talks about how our mental health is actually getting worse and worse across the country, and of course in Kentucky as well. I will say this. I'll pause long enough to tell you this, though. What this model represents, it addresses a gap in almost every community in Kentucky. The ability for someone in a crisis that they define themselves to be able to walk in the door and see a provider within 30 minutes, to be able to have a place to stay for the next 23 hours, to get treated immediately. And then we make a decision on if they need to go to outpatient services or to inpatient services. Apologize, Lindsay, I'm stealing all your slides. Just a couple of, there's lots of literature out there. I would encourage you just to go to Google and type in Empath Center, and you'll see lots of articles in different cities and states that are doing the same thing. So this is well publicized. This next group was an article was in the New Yorker, and it really emphasized, this was an important article because it emphasized the therapeutic nature of the space. I'm gonna let Lindsay tell you a little bit more about the space, but it is as significant as any medication that they may get in an empath center. Lots of different benefits for systems that are interested in doing this. So why now? So Dr. Jasinski has worked with a lot of different of our health insurances and really paved the way for other hospitals, really a guideline and a roadmap for how to do this. So a lot of this wasn't reimbursable and it wasn't covered, and all of that pathway had to be navigated. Dr. Jasinski has done a significant amount of that work for hospitals and institutions. And so what we know, the benefits for systems of healthcare is that it reduces, hospitalizations, number one. It reduces the amount of, it declogs the ED rooms, so you don't have your behavioral health crisis going on along with your physical crises as well. And just a lot of other things here. You'll see like an 80% reduction in admission rates. So many more she's going to share in a bit. So benefits for the community. Again, it does address stigma in the community. You'll notice we've listed incarcerations there as well. Why? Because the police don't have to pick someone up that's not acting right and take them to jail. They can take them to the Empath Center. And so we've been working with Judge Tackett in Fayette County about how we can do that. How do we coordinate some of our work with mental health court that he spearheads as well. And it's a least restrictive environment. It's 24/7. People can drive themselves up to this. There's an interesting story about stigma that we'll share towards the end as well. One of the stories that a family shared with us. I'm going to zip through some of the benefits, lots of benefits. I'm going to give it over to Dr. Jasinski so we could, again, be good stewards of our time.
If you want. So we opened this on July 30th. This has been several years that it's taken us to get to this point, just because this is a really new thing. And these are some of the articles that have come out on our Empath Center. And like Dr. Wood said, we want other people to be able to use this model, and we want to be proof of concept. And we'll share some data with you, but Dr. Zeller, our national consultant, did say that he's not seen a media coverage of empath centers as they've opened like we've had in Kentucky. So our communities are embracing this. And I was shocked when we opened to see just the comments on social media of this is amazing, it's so needed, this is significant change in our system, which has just been phenomenal. So I'm going to talk a little bit about the operations. So this is located on Eastern State Hospital campus, but it's not, we run Eastern State, but we are UK Healthcare employees. And this is a UK Healthcare run and operated, fully owned by UK Healthcare clinic. And so while it is located on our grounds, it has a separate entrance. And that's important because we don't want folks to think, oh, I'm coming to a hospital. This is just an easier way to get me into the hospital. That's not true. What this is a way for us to treat folks in a behavioral health safe environment that already existed. We were using space, so it was much more cost effective to have that space and use it. And I'll spoil it a little bit, but about 70 to 75% of the people that have come to us so far are going home. They're going back to the community. So we actually have very few that are moving on to inpatient hospitalization. Like Dr. Wood said, the space is really important. So when you go to an ED, if I showed up at the ED today for depression, suicidal ideation, whatever it might be, I am going to be put in a room, likely by myself. I might be put on a 72-hour hold, and I might have to have a security or another staff member sit in there with me because the environment is not entirely safe. So I have to have someone follow me to the bathroom. I have to have someone watch me all the time. I then sit and I wait for a psych consult. I get a psych consult, and that psych consult says, yes, you need to go inpatient, or no, you can go to outpatient services. That decision is made, and we move on from there. Empath is completely different. So the important piece of this is the treatment core. And what that means is I come into Empath, I see a behavioral health provider immediately. I go into a wide open space. I'm not by myself in a room. That space is this picture on the right where you get a recliner chair, you get a blanket and a pillow, a meal, a snack, a shower, clothes washed, whatever you might need to meet those basic needs, and see a behavioral health provider. Then the next thing that happens is not a decision whether to go inpatient or outpatient. It's treatment. It's medication, it's peer support, it's therapeutic services. It's all of those things, because what we know is with that treatment, up to 70% of those people can be stabilized and go back home. They don't have to go inpatient. So we avoid that entire hospitalization by treating. We get medications on board really quickly. We get therapeutic interventions started. Our peer support are meeting with them. And for that first 12 to 14 hours, we're treating. That's what we're doing. And then we're making a decision on whether someone needs to go inpatient or outpatient. And that rapid access to treatment is really what makes this different. It's not a psych ED in the traditional sense. It is truly a treatment-based facility. So we'll kind of flip through the rest of the pictures, maybe. This is a wide open space. It's not an enclosed nurses station. It's not a space where the staff are away. The staff are sitting in that therapeutic space with the patients at all times. And it walks and talks just like any other clinic where we would be able to do a medical exam. We can draw labs. We can do all of those things that we need to. We also, on the right side of that last, you're pushing me along. On the right side, we also have an outdoor patio, which is very different. So rather than me going to an ED and having to sit in a bed and I'm anxious and I want to move around, but I have to stay in that bed because that's where they're watching me, I can walk up and down the hallways. I can roll my chair down the hallway to a place where there's a big picture window out to nature. I can go out on the patio. Can't smoke, but that is a question that we get often. But I can go outside and get fresh air, and I can listen to the birds, and I can do all those things that are calming and therapeutic. This is a busy slide, but what it shows is how people get to us. And the answer to that is any way that they come to us, we will be able to take them. The police can bring folks, EMS bring folks, family members can bring them in. They can take the bus to get to us. They can get to us any way, and we will take them. The one way that we cannot take them is if they are already under a 202A. Those would have to go to Eastern State because Eastern State is the designated 202A provider. But anybody else can come in emergency detention, a guardian can bring them in, whatever it might be. So far, of the people that we've seen, about half have come by private vehicle, and another third to 2/3-ish are coming by ambulance. And so folks are just driving up. There's parking, they come in, the family members, there's a waiting area for them too. So like Mark said, this is 24/7. If there's we don't determine when a crisis happens, right? It might be 2 a.m. We take anyone as soon as they come to us. They are seen by a provider immediately. Our provider is on site 24/7. It is EMTALA compliant, meaning so we see individuals age 18 and over in this setting. We had a 13-year-old show up last week. That 13-year-old was medically screened and seen by a provider deemed safe to transport, and we transported them over to Kentucky Children's Hospital to their emergency department for evaluation. But anybody that comes to us, we will medically screen them. We cannot turn them away because of EMTALA. We then utilize 23-hour observation, so they can stay with us for up to 23 hours. And we have 12 to 16 chairs. We have been up to 16. We have hit that capacity. And we're already starting to think about how do we expand this. I think the rest of those I've covered. Oh, and oftentimes we get a question, can this be substance use related? The answer is yes. It can be behavioral health. It can be substance use. We can work with all of those things. Go ahead. So in terms of operations, this walks and talks much like an ED, but it is a very different environment and course of treatment. Like Mark said, it's very low barrier. So we have very few exclusions. They would be if the person needs additional medical clearance. So if they have taken an active overdose and they need additional medical clearance for that, those would go to Good Samaritan ED, for example, and then they would come to us after that. But there are very few things that we are not able to work with. We have seen significant improvement in decompressing our local EDs, and folks are coming to us and getting treatment faster. And then we work with them to get them back into the community. We also have transportation on site, so we can take them back home. Many of our folks come in a way that they cannot get back home, and so we will drive them back home, or we'll drive them to whatever residential substance use treatment or whatever facility they're going to. Oh yeah, that's another significant benefit to our system has been our close observations, or having a one-to-one staff in our EDs has dropped significantly with these patients coming over to us. So just some updated data. How's it going? We've been operating for 6 weeks. I looked at the data this morning. In 6 weeks, we saw 530 patients in our first 6 weeks of operation. About 75% of those, like I said, have gone back home. We have seen people from all over. I actually looked at the data this morning. We've had somebody from the state of California who was in town visiting. They were in a behavioral health crisis. Husband brought them in. We stabilized her, got her on medication, and she was able to fly back home. So we've seen people from all over. I think we've had 8 or 9 states now in total. It's about equal male and female that we've seen. We are able to, which is unheard of in ED, get people directly into residential substance use treatment. In fact, we had 2 leaving today that were going directly into residential substance use treatment. Our peer support have been a huge, huge, huge benefit. Our average age is somewhere in the mid-30s, and we have seen, so we're working with New Vista. New Vista actually has a staff member there 24/7 with us. Pre-empath, our follow-up rate, so how often people made their next appointment, was 29%. Post-empath, it's 55%. So we've nearly doubled the rate at which people are getting to their appointment, which is huge in keeping them in care. So we are getting patients from all over. This continues to evolve. I put these slides together on Friday, late last week, and this is very different even today now, given the numbers that we've had. This is a really, really great model. And I can tell you, we've had our own internal skeptics within our organization who said, I don't know. One of our nursing directors is an ER nurse for years and years, and said this model is truly changing our system. And I think it's going to continue to do that. So I don't know if we have time, but we're happy to answer questions after as well.
I think we have time for a question or two here if anyone would like to ask.
I'd like to ask if it's possible.
Most common.
For Nelson County to be a pilot county, to have you all come to their, come out and
100%.
maybe through telehealth or something, but this is fantastic. It's just,
Yeah.
it's the best news I've heard in my career. Thank you.
We had a hard act to follow. I was like, man, such good news. How are we going to follow that? But it really has been great. And Mark reminded me, one thing that's been interesting for us is to see the reason that people are coming to us. More than half, it's been about 60 to 65%, have been coming in for suicidal ideation. That's kind of the primary reason. And this is something that can save people's lives. I mean, it's huge. So, yeah.
My question was along those lines. I don't know if you see any veterans or anything like that, but with the Compact Act, are you guys tracking that
We're not yet, but it's
I-
something that we might.
I'll
Yeah,
talk. I'll talk with you all offline.
for
But
sure.
for the others, what it is any eligible veteran, if they have suicide ideation, they get VA covered treatment up to 90 days, and that can be extended, covered by the VA.
Yeah.
So I'll talk to you about it.
Awesome. Yeah. It's something, and we have social workers there from 8 a.m. to 8 p.m. every day. So they're working on, discharge planning.
Transportation back home. That's
Yeah.
one thing we didn't add either.
Yeah.
So we take our patients that are there. We've got full-time transportation staff that we call therapeutic transportation because they're not just drivers. They're actually highly trained to be able to connect with the patient while they're taking them home, to keep encouraging them. So it's just been and we invite anyone to come. We'd love to show it off. We want you to see it.
Oh, right. There's a great place to interject. We're going to pass around a sign-up sheet for our commission members if they would like to participate in a little road show to see you all. We'd like to see
Absolutely.
both the Empath program and the Eastern State program.
They're so great. We'll absolutely. We'll pick you up.
How feasible do you think it is to replicate this in other Kentucky communities? And what do you think is the level of awareness of this program by other hospitals and universities in Kentucky?
I think it's growing. The level of awareness is certainly growing. We've had tons and tons and tons of people reach out. Like, we're having trouble keeping up with the requests for people to reach out and come see us. And it ranges from hospitals to community mental health centers to other agencies that we're working with. And we've hosted lots of tours. I think it continues to grow. In terms of feasibility, it's doable. If we can do it, it's doable. And you can scale it to whatever. I mean, there might be a smaller regional hospital that wants to do this with 4 chairs rather than 16. It's very scalable to do.
Yeah, we would be remiss if we didn't mention Vituity and Scott Zeller and the team that we worked with to kind of put this together. But we'd be happy to work with any organization. And for the longest time, for many, many years, there were just hospitals weren't interested in this because you couldn't sustain it because you couldn't make money off of it. You couldn't even keep it supported. That's not the case any longer. You don't make a bunch of money as an organization, but it's definitely sustainable and it benefits your system greatly.
And we've actually, through this process, we've learned a lot. And we've actually written a manual for how this can be done. There is one for how to do it in California. We adapted that, and it has job descriptions. It has all the information that we literally can hand to an organization and say, hey, here's how you do this.
Wes? All right.
Thank you all so much for having us.
Thank you. We'll see you soon. All right, next we're going to move on to committee and work group updates. In your materials, you'll find the quarterly reports for all the work groups. And first, we're going to start with Judge Tackett for the Criminal Justice Committee update.
Thank you, Chair Justice Lambert. I just want to add on to, it's just dovetailing Dr. Woods and Dr. Janicki. It's just been a marvelous program to work with Empath for the first 6 weeks. They've been in operation and we're really excited. And just to tell you a real quick story, I was talking to Judge Mullins, and it's so hard for us judges to pinpoint. You see someone in the courtroom and they're acting erratically, and you have reason to believe they're either probably under the influence of substances or potentially, experiencing a episode. And judges, what's our one tool? Hold them in contempt, potentially put them in jail. And here, we've been fleshing it out, and we've determined that we could probably, call the paramedicine team to come to court, have them assessed, and then instead of putting these folks in jail, we're sending them over to Empath, where they can be assessed and to determine whether it's, something voluntary or not. And even if it's substance use derivative, then we can be looking at treatment. So, and in respect to that, just one other real quick story. I had a gentleman with in my mental health court, he admitted to me that morning he was acting really erratically, and he had kind of like a word salad going. And he had said, "Well, I'd used THC," and he'd driven, to court. So, I mean, judges, what do you do? I mean, you're not going to let him leave and drive intoxicated home. But we were fortunate because under that circumstance, he was willing to go to Empath, said, we can't let you leave. And we had the sheriff, I know next time, paramedicine team, but had the sheriff transport him over to Empath. And he was so sick and ended up that he ended up getting admitted. So, I mean, he really needed an intervention, and it was we were able to work it out. So I'm just thrilled they're here. I'm thrilled for the great working relationship we have with Dr. Woods and Dr. Chudinski. And yes, if you are thinking about it, I highly recommend trying to get something started in your community. So now on to the Criminal Justice Committee reports. Again, you got me instead of Judge Mayer. She couldn't be here, so I am a sad substitute for her. She sends her regrets. But I'd like to just first off thank Shauna Mitchell, Jennifer Van Ort Hazard, and Maria for the just incredible support that we get from them to help us do these committee reports. So they've just been wonderful, and we just I can't thank them enough. I'm always impressed when I do get to see. I don't often get to the work groups, but I'm always super impressed with the work that's being done as much as I can get there and be exposed to it. So also just thank you, Justice Lambert. She's going to come to our district court judges conference next week, and she's going to tell all the district court judges, all my colleagues, what's going on with the commission. So I just wanted to put that in there. We're very thankful that she'll be attending our college in Lexington next week. So without further ado, we're thankful to have Steve Shannon jump in. Can't thank Jim Ross and Jim Daly and Joe Ross enough for their work. But as Justice Lambert said earlier, Steve Shannon's going to be our new work lead for the pre-arrest diversion program. So Dr. Slusher, I'm going to turn it over to her, and she'll tell you about competency.
Hi, everybody. All right, since we last met, SES law went into effect, and so we have been working as a work group to identify all the stakeholders that need some solid messaging around process or barriers that the system's facing that we can help overcome. So we've met with several stakeholders, including the Kentucky Association of Counties and the Kentucky Jailers Association. Sean and I are going out there to their yearly conference in October to present with them about SES law and how the process has worked so far since we piloted this through KCPC. And we're going to have Kenton County join us and Louisville Metro Department of Corrections, who's been doing it for a long time, so that they can hear from jails how this process works well. And we are also going out next week to the Kentucky County Judge Executives Association retreat so that we can provide information on SES law to them as well. We met with Dr. Fikes. He has served as kind of a consultant for our competency worker. We've talked about him before. Of course, we modeled our legislation after Tennessee's. And so we met with him since we last met to talk through how Tennessee handles patients who refuse video conference evaluations or outpatient evaluations. And we've been able to get some really solid feedback and then provide some technical assistance to our evaluators across the state on how to handle these cases. And that has been really helpful. We have also met monthly with KCPC and Dr. Sussman, who is on the screen, from DBH with all of our state hospitals so that we have been able to streamline process. As a reminder, SES law affects not just felony cases out of KCPC, but all misdemeanor cases across the state hospital system. So we've been kind of acting as TA and consultants for the state hospitals to make sure they have what they need to be successful in this as well. And we met with them this week and heard from them that this has brought down their wait time significantly for misdemeanor cases as well. Outpatient wait times for KCPC, when we worked on CES law, and we're giving out information about how long it would take to have an outpatient evaluation. We said about 3 to 5 weeks. Sometimes that goes up to 4 to 6, but right now we are operating in real time, and that's happening in about 2 to 3 weeks. So there's very limited wait times for people to get this service, which we're all very proud of. It's the cheering squad over there. As we think about continuum of care, it's not just about outpatient evaluations, right? But it's about diversion, deflection. It's all these wonderful things we talk about as a commission. So Council of State Governments also connected us with some subject matter experts on FACT teams. That is something I know as a state we're really interested in, and KCPC is particularly interested in how we can bring about FACT teams because of our 202C population who could really benefit from those kinds of models in order to be successful in re-entering our communities. So they were able to give us some good information there that we're going to build off of in the future. And you'll see in your packet some legislative recommendations from this work group. It has to do specifically with payment for guardian ad litem, which are part of the process for 202C patients, and the role of the guardian ad litem. So that's in your packet as well. Always like to give an update on where KCPC's wait list stands. About 18 months ago, we had 365 people or so waiting for a service at KCPC. As of this morning, we have 158, 20 of whom are on bond. So that means 130. Now, never hold me to these numbers, right? I always try to say that on the front end. They change every day. But 158 waiting for an inpatient service at KCPC, 20 of whom are on bond. So that means 138 are in custody. Prior to the pandemic, prior to these massive system changes we've implemented through KCPC, we had 130 people on the wait list. So we're about where we were before. But this is kind of always how the system will operate because people are going to stay at KCPC longer, as you remember me saying every time, because that's an indicator of success. We are getting the people who need KCPC inpatient services more, which means they stay longer. So our bed turnover is always going to be a little bit slower moving forward, but that's a key indicator of success. Of those 138 who are in custody, 27 of them are non-flexible orders that we received prior to implementation of CES law. So we are not allowed to be retroactive with CES law. We have to go ahead and honor those non-flexible orders. That means they required inpatient, though we said we could see them outpatient. So we're moving through those. If you remember my numbers before, those were like 60, 70, 80. So we're down to 27. We also have 10 orders that we've received that are non-flexible orders post-CES law that we're providing education to the court and getting their feedback on how they can work with us to give us a flexible order and get those patients seen quickly. And I think that's everything, unless there's any questions for me.
Any
All right, thank you.
questions?
Questions?
Okay.
All right, thank you.
Now, Judge Jones with the Juvenile Justice Work Group.
Thank you. So we have divided ourselves into two subgroups, the Juvenile Justice Work Group has. So we now have a legislative group that is focusing on changes that will be needed to the statutes, as well as a group that is focusing on the results of our mapping survey and looking at pro-social activities and looking at community interventions. So our focus moving forward from our legislative group, once we have met, we want to thank Maria very much. One of our legislative priorities is looking at creating an age of competency for Kentucky. I know this has been attempted several times in the past, but it's something that really needs to be done. Right now, we have a 3-year-old in Kentucky charged with a felony offense. And that's something that whether you're red or blue or any color in between, that's not right. And common sense dictates that something needs to be done about that. So we think that we can move forward trying to bring some consensus to a legislation to come up with a common sense age of criminal responsibility in Kentucky and hopefully move forward on that. So we are investigating the laws in other states that have done this, what their ages are, what they've based that age on, what research they did, and what experts nationally that we can reach out to help advise us in this process. So that's one of our legislative goals. Another is to come up with competency standards, not just age of competency, but competency standards. If you have a juvenile who is found to be not competent to move forward, we don't have a KCPC for juveniles. And so what that process is, and we don't have any laws on the books right now in Kentucky about that, and not a lot of places do. So we're looking at those that do have those and trying to come up with what the process in Kentucky should look like. We are also looking at training for community-based providers to develop those pro-social activities in our communities, and reviewing crisis stabilization for youth. If you're lucky, you've got a adult CSU or empath program in your community. If you're very, very lucky, you have a youth CSU, but there are not a lot of those throughout the state. And so that's one of the things we want to look at moving forward, or what the feasibility of expanding that type of program is. I also want to mention in the same lines, I was recently at River Valley Behavioral Hospital when they opened what they call the Birch program, and that was a collaboration between the hospital there, River Valley Behavioral Health, which is one of our state community mental health providers, the Department of Children and Family Services, Medicaid, the Department of Behavioral Health and Intellectual Disabilities, all came together on a pilot program. So the Birch program, believe, has 12 beds for high acuity youth who are placed with the cabinet, who need long-term placement to become stabilized, to try and find other placement for them. They've already, at their grand opening, they already had one youth admitted into the program, and that young person had had 30 placements over the course of their time in state care. So this gives the cabinet and everyone who's looking for a place for these youth, and a long-term place for these youth, a place to help them become stable and hopefully help them move forward towards long-term stability and a place out of hospitalization. But just wanted to announce the opening of that program, and that it is a collaboration between so many of the people we have around this table. So thank you all.
Thank you, Judge Jones. Does anyone have any questions for Judge Jones? Okay. Moving on, as again, Steve Shannon couldn't be here for the pre-arrest diversion program. There is a report in your paperwork. I'm not gonna read from it, but I will hit a couple of highlights for the pre-arrest diversion group. Unfortunately, this is a group that I try to get to, and I have a conflicting monthly meeting, so I get to be a part of it for about 30 minutes or so. But they've received presentations from police with regard to police social workers and jail services. And right now, this work group is discussing, I think they're finalizing their survey to do the local jail mapping and needs throughout the Commonwealth. They also had a presentation from Jailer William Hensley on the Boyd County Reentry Program. And that presentation underscored the work group's commitment to exploring services within jails. I was part, and I did see half of this. The work group had a presentation from the Kentucky Department of Public Advocacy on their alternative sentencing worker program as well. And that they are reviewing updates on jail surveys in Senate Bill 90 with plans to delve deeper into these topics. So right now, I think that's their main motivations or main goals, is to do the mapping, the jail types and services through a statewide jail survey rather, and finalizing the draft of the police social worker white paper. So I'm not going to be able to answer any of your questions, but I would recommend if you have questions to talk to Steve Shannon. So I'm going to go ahead and move on to Erica Hargis for reentry.
Thank you. So the reentry work group is our newest work group, and we joined the committee and started doing some work. So what we started with doing was getting presentations and learning where we are before we can decide where we're going to go. So we also heard from Jailer Hensley. He's been making his way around the work groups apparently, which is good because he talked about what he's doing at his Boyd County Jail and helped us to understand what were some things we could learn from him that may be able to be replicated at other jails. We also talked to the Reentry and Employment Services branch about the work they're doing, and they highlighted the different education opportunities available in Kentucky for this population. We also heard a presentation from the Chamber Fair Chance program. They support Kentuckians in achieving long-term recovery. So now is where we're at a crossroads, and we are ready to develop our work plan. I think that our committee members have a lot of things rolling around in their head, and they are ready to put our plans to action. So now that we've kind of covered what happens within the Department of Corrections for mental health with our last quarterly meetings, then we talked about what's happening in jails. We've talked about what's happening in different cabinets with community partners. I think we're ready to move towards putting pen to paper and saying, okay, what are these 30 plus people? What are we going to start working towards? And so that's where we are. Maria has helped us compile our legislative ideas, and those had been sent in. Jen's been keeping us on track for all of our meetings and making sure that our guest speakers were prepared. So shout out to them. Thank you all for that. So next time that we do a report out, I think we'll have some really exciting things and hopefully some deliverables. So thank you all.
Any questions for Director Hargis? Okay. Justice, I think that's a wrap for us.
We now have Judge Foster Cutoff from the 3rd Judicial District to give us a report on the Civil and Family Justice Committee.
All right, good afternoon from Hopkinsville, everyone, and I'm sorry I couldn't be there today in person, but the judge who normally covers me is covering another judge in Livingston County over in Smithland today, so I had to stay and do my docket. So here I am. I will say I'm excited personally about the fact that Christian County is getting one of the 10 mental health courts that were in the judicial branch budget, and we're in the process of getting that started. And we've got community meetings planned, and we hope to get that off the ground in January. So I'm excited to be heading that project here. I was also excited to get to introduce Shauna and Jennifer at the ROSC Summit in Paducah on August 13th. It was nice to see them there and get to listen to everything that everybody had to say at that particular summit meeting. So just some things that going on with me. I'll stop my personal time now, though. With our Civil and Family Justice Committee meeting, we do have a new vice chair. Chris Griffiths is our new vice chair, and he's probably there. I don't know who's there. So I do appreciate him taking on that role and helping out our committee in that way. Our work groups are meeting. I get meeting notices all the time, and like Judge Tackett, I can't always attend, but I like to try to keep up with it. But they're also creating various subgroups, and they're actively progressing their work plan priorities in these subgroups. The focus that we're going for right now with these actions are developing education and training materials for judges, clerks, counsel, community supports, and families. We're exploring communication methods and existing resources to enhance collaboration between system partners, as well as with families and custodians in the families. And we are also reviewing our proposed legislative changes that we're looking forward to presenting later on, and hopefully possibly getting something done in 2025. With regards to our work groups, Judge Brown, I do not believe was able to be there today. Denise Brown leads our domestic violence work group, and I am also not going to read to you. I'm going to refer you to the materials that you were given today with regards to their report, so you can read that on your own. But I do know the other two work group leads are online, and Judge Marcus Vanover leads our Dependency, Neglect, and Abuse Work Group. So Judge Vanover, I will turn it over to you.
Thank you. So our work group, the DNA work group, met again August 6th and received updates from our various teams within the work group. One work group is working on enhancing collaboration and communication with system partners. And they are doing this by creating a series of trainings called Relationships Matters Part 2. There was a first version of this was attempted a couple of years ago with some success between the cabinet and the judiciary, and now we're looking to expand this to include more system partners to the table. Some of the topics that are being discussed for our trainings, one is related to compassion fatigue, moral injury, secondary trauma, PTSD, and mindfulness. We're hoping to be able to put a training together to benefit our system partners regarding that. Another topic is various levels of professionalism and how our partners in the judiciary and DCBS and attorneys all work together. We're working on a MOUD/SUD/MAT training so that we know what the best drug testing options are and what the limitations of those are, and the effects that the brain may have from stress and substances and things of that nature. There'll be another training regarding ACEs and resiliency. And the final segment that they're looking at right now is coming up with a training on intellectual disabilities and high acuity youth, to include a primer on mental health and the DSM. So those are the ones that they're working on now, but we think that this is something that as the trainings occur, that we can look at expanding and maybe keeping this as an ongoing activity and an ongoing partnership. Let's see, we're still working on our bench card for understanding the roles of our treatment providers. We're getting very close on that. I told them my goal for that one is to be able to have a finalized version to hand out for judges at the judicial colleges. I'm thinking we may miss the district college next week, but maybe we'll have it by the circuit college at the end of October. Let's see, we're still working on our lost track of my place here, and I can't remember resource guidelines, getting the finalized edits on that as well. Again, we're very close and hope to have that done very shortly. We finally have a fourth work group now that has started earlier this year. They are working on training for our DNA counsel for the court-appointed attorneys and guardians ad litem, working with the administrative office of the court's legal department to review that and to come up with additional trainings that we may be able to implement to make sure that our court attorneys that are working in the system have all the resources they need to adequately represent their clients, whether they be the children or the parents, and specifically to deal with the growing scope of mental health concerns that are involved with our folks in the DNA courts. I think that works as far as the work group and the work that they've been doing. The last thing I do want to say is for those of you who are judges or other individuals that work with the justice system. We did the first community mapping in Pulaski and Rockcastle counties. It was very eye-opening and rewarding, frankly, to be able to learn more about what's going on in our community regarding substance use and behavioral health. And I urge any of you that if you have a court and want to get signed up for community mapping, try to get on the list. If you are in a community that has a community mapping coming up, try to find out and stay involved in that. It's very rewarding, and you can learn a lot about what tremendous work is going on in your communities that you may not have been aware of, that is dealing with addressing mental health concerns within your area. we had several people at our meeting talking about that, this is great. We didn't realize that these resources were there, but we certainly are going to be able to use them. So everyone who participated learned a lot, and we have some work groups already coming out of that that are getting started. So again, if you have an opportunity, get on the list or attend one of these events and see what your community is doing. And that's all I have.
Thank you, Judge Vanover. And that's a very nice Western Kentucky University lanyard you're wearing. Go Tops, right?
Go Tops.
All right. Does anybody have any questions for Judge Vanover? I really appreciate everything he does with his work group. They meet quite a bit, and obviously, based on his report, you can tell they do quite a lot of work. So thank you very much, Judge Vanover. The last work group we have, or actually, I guess, two different work groups that started as guardianship and commitment together, but Stacy Tapke, our Kenton County attorney, leads those two different and specific work groups now. And I think Ms. Tapke is also online.
I am, and hopefully you can hear me. I have a
We
new
can.
computer. I have a new computer, so I can't figure out the video, so you can't see my awesome Purdue University lanyard. But I know you'd be jealous.
I'm
So-
truly jealous. Yes.
But for guardianship, we have done a lot of work this last few months. We've met regularly, and we really comprehensively reviewed all of Chapter 387, kind of a discussion of where we can reach consensus and issues that need to be addressed. And overwhelmingly, agreement is that the word ward is antiquated and really should be replaced. Possibly with person under guardianship. And we're continuing to also work on a restoration of rights order. AOC has been generous to create that. And we're in the process of reviewing it for feedback, because when people do get their rights restored, they encounter issues when they go to banks and medical providers. The order itself of guardianship and conservatorship are really nice and fancy. So we need a really nice and fancy order of restoration of rights so that those will be honored. So that's what we're working on there. Our commitment work group is continuing to meet and just discuss KRS Chapter 202A, as everybody on here knows and recognizes, just all of the challenges with how we do involuntary hospitalizations in Kentucky. So we're continuing to learn and have presentations about it, and looking at how we can better improve the process, including improving the forms. We're working really hard to try to create some educational materials, one for the process from a law enforcement perspective, one from a family perspective, and one from a court perspective, of just answering questions that come up along the way, and also just trying to map out the process so that somebody can look at it and very quickly understand a little bit better the process of how it works. So that's what we're up to. Thank you.
Thank you, Stacy. Does anybody have any questions for her with regards to either the guardianship work group or the commitment work group? All right, Justice Lambert, that's our report. Thank you.
Thank you, everyone. Now we will turn to the Treatment and Access Committee reports with Judge Kevin Mullins.
Since our last meeting on Thursday, June 13th, we've been very busy promoting Senate Bill 90, our Treatment and Access Committee, and the commission as a whole. A few days after that meeting, Representative Moser had invited a number of us to present at the Interim Joint Committee on Health Services. Van Ingram spoke about new trends in our fatal overdoses. Shauna spoke about the work of the commission with some specific emphasis on the sequential intercept mapping that was going on. I was allowed an opportunity to speak about some wonderful and amazing legislation that our General Assembly had recently passed, referring to Senate Bill 90. also referring to Representative Moser's House Bill 353, which was the fentanyl testing legislation, which also had a portion of a correction to Senate Bill 90. So as someone who was actually working on a program and actually experiencing a problem and within months having that problem addressed was just very wonderful. Also, I was able to speak quite a bit about Senator Adams's Women's with Dignity Bill 1 and 2. And in all these different pieces of legislation, we were able to show how these particular pieces were able to positively influence and even save lives of our Kentucky citizens. So it was a great opportunity. Who presented that day was Tom Stevens, a new member here today with the Kentucky Association of Health Plans. And I'd like to welcome Tom here. And I would also like to say that I have consistently admired the Kentucky Association of Health Plans, how proud they are of the treatment and recovery system that has been established in Kentucky. So I just wanted to state that. Shortly thereafter, in July, we had a recovery event in Whitesburg. We call it Recovery Central. At that event, Justice Lambert, Shauna, and I think Yacinda is hidden behind Dr. Sessions over there, were able to attend. We had presentations during the morning. We had a play after lunch. And then also, while that was going on at the courthouse, the Justice and Public Safety Cabinet sponsored an expungement clinic in my courtroom. They had limited it to 50 participants, and in fact had 50 participants. And I can tell you, in dealing with 50 people in 2.5 hours of time, and walking in, it was kind of this beautiful chaos that everyone got to experience. With that, I would like to thank the Hazard Public Defender's Office, which had that event well staffed. I would also like to thank Goodwill Industries for their race program that was present during the course of that event. A few days later, we had a fishing tournament called Gone Fishing, and that was working with the Cabinet for Health and Family Services, designed primarily for fathers who were at risk or who had lost and recently regained custody for substance use disorder. And that as well was, that was sponsored as well by Operation Unite. On August 6th and 8th, Operation Unite had their coalition symposiums in Corbin and in Prestonsburg. The title of that was Don't Stop Believing. Elizabeth, who's behind me, seems like everybody I'm talking about is directly behind me. Elizabeth spoke at both the Corbin and Prestonsburg event. Shauna spoke at the Corbin event. To my knowledge, those events were very well attended. I think 29 of their 33 now coalitions had members present at both those events. I was allowed to speak in Prestonsburg, and I was allowed at that event to share my opinion, which is that Operation Unite is the greatest regional grassroots movement to combat substance use disorder in the history of man. And if you debate that, I have the numbers that back that up. We all seen Tom, and we heard what incredible amounts of children they were able to reach just this week. So that's amazing. Towards the end of August, we had our committee meeting, and we actually had a presentation very similar today on the Empath program. Previously, you've heard Judge Tackett talk about how envious he was of our Senate Bill 90 program. So now I guess we have a mutual envy, because I am so envious of this program and the ability and how many people that this program has helped already, not just in Fayette County, but Central Kentucky. And I have to apologize to Judge Tackett, because when Justice Lambert was calling on him, I was over here, hey, John. Next week, we have our District Judges College set. And as part of that, I have an hour presentation on Tuesday, which is just kind of what I'm going to consider a warm-up. And we're just going to talk about why the court system's involved. And it's mainly due to the prevalence of substance use disorder and behavioral health concerns. That's like before lunch. After lunch, there's a 2 or 2.5 hour presentation that Justice Lambert, John, I think Dr. Clark, and some other people from UK are doing as basically as to the intersection between the court system and the behavioral health system. So when I was trying to get John's attention, I'm like, wow, what a great time. Maybe that evening we can go to Empath. So you might get some unexpected visitors on Tuesday afternoon. Yeah. Last Thursday, I was part of a panel discussion with Dr. and former Senator Ralph Alvarado, who's the Commissioner of Tennessee Department of Health, ETSU, and the Fletcher Group about understanding the health of Appalachian communities using it and using data to make a change. That was at the Appalachian Regional Commission Annual Conference in Chattanooga. There's been a lot of interest on our Judicial Commission. There's been a lot of interest on our Senate Bill 90 projects. I think there's some of us that are planning on attending a presentation in October with the Rockefeller Fund. As mentioned earlier this week, I think was the conclusion of the recovery-oriented system of care training. I think the Frankfurt was the last event. Again, I would thank everyone who was involved in specialty courts, Justice Lambert and Shauna for presenting at those events. I think this 7-part summit or series is kind of the classic example of what I've always said. I think for the Treatment and Access Committee and this commission to succeed, I originally thought about it on 2 words, and that was education and determination. And it clearly fits the bill there. It's clearly education. It clearly requires the effort. It coincides, the Treatment Access Committee has been just so blessed. The town hall meetings, our summit in Louisville. We've just gotten so many great gifts, but just the same as the recovery-oriented system of care. I've kind of now, in going through this, I guess we need to add a 3rd word, because I think it's really going to be education, determination, and collaboration. Because if you notice, all of us are doing things on this together. We're all working together, in different aspects of this. So to me, that's the 3 words that we have to focus on. I would just kind of like to end what I'm saying. It is National Suicide Prevention Month. It is also National Recovery Month. With that, I assume there's some event going on in almost every community. And if so, it'd be a great opportunity for everybody to get out to those events, spread the word, get more involved. So with that said, I will turn over to the work groups. And on the agenda, the first listed work group is the Intellectual and Developmental Disabilities Work Group led by Crystal Adams. And they'll...
Not that I can't be loud if I need to. So since the last time we met a quarter ago, we have continued our work with autism in the courts. We were actually contacted by the Autism Justice Center, which is under the Autism Society. Their local chapter here in Kentucky has some individuals who are involved in our work group and had shared information with the National Autism Society about what we were doing here in Kentucky. And so Carlene Ponder, who is their director over the Justice Center, had asked to meet with us and talk a little bit about what we were doing. And so we were very happy to brag about the work of the entire Justice Commission, our work group, and what we have hoped to do with autism in the courts. At a national level, they're looking very much at policy, education, advocacy. And so they were very excited to see that Kentucky had decided to focus on this initiative, and we're looking very forward to seeing what we come up with. And we think there'll be a lot of opportunities for collaboration between our 2 groups as we progress. Next, what our group focused on, we looked at concerns with lack of disability-related data across the system. Unfortunately, it's difficult sometimes to know what the full scope of individuals with disabilities involvement with the justice system truly is. We don't always have the data that we need to do that. So one of the things we have talked about doing and started doing some work with is identifying key agencies across the system and looking at what is already currently available. We've had some discussions particularly and are having additional presentations on data related to our court designated workers and the data that they collect, some education related data that's available. And then we're looking at other key partners and trying to determine what data they may collect. And then we're looking at kind of standards. Are there any standards that we can pull from across the country and make our own recommendations for what should be the standardized data that we collect on disabilities across all of the different points of the system so that we can get a better idea of what's really going on and what the prevalence is of individuals with disabilities at different points across the system, and therefore get a better idea of what we need to target and move forward. We also continued our work on self-identification systems for individuals. We had previously in our last quarter talked about how we'd had presentations on Light the Way Home. We reviewed some of that and some of the other models like the Yellow Dot program and talked about those a little bit more. There continues to be interest from our work group in pursuing this topic. We did talk about some of the potential concerns related to the disclosure of potentially sensitive information, especially for someone who may be going through criminal proceedings. Steve Shannon had led some of that conversation for us, who has gotten several shout outs today. So I'll give him another one. And then he was kind enough to reach out to DPA and have them join us to talk through some of those concerns and insights from their perspective in their role as attorneys for individuals going through the criminal justice process and the risks and benefits of having this type of a program in place. So we plan to continue to have discussions about the topic and what we might want to pursue and look at moving forward in terms of opportunities for individuals to self-identify as having particular needs or information for first responders and other folks in the justice system to know about them. We had a presentation from the Department of Transportation related to the restoration or loss of driver's licenses related to disability. It was a very interesting discussion. I think most of us learned a lot of information we didn't know about the two different processes that are involved. There's medical review that can be impacted if you are identified with a disability, as well as the legal process that can occur. For example, when someone gets guardianship rights and over them, and then when they get their rights restored. So that was a very interesting conversation. I know I found some things in there that I think there's opportunities for us to discuss further as a work group later in relation to that. But our primary goal was really just to better understand that process ourselves as a group so that when issues come up and people have concerns about going through that process, that we can help guide them to the correct individuals and let them know how that process is going to work. We finalized kind of our legislative recommendation. We had one that was put forth for the work group, which you can find within your packet. It is related to amending language, both related to adoption and related to individuals and having their rights terminated for as a parent related to disability and trying to prevent that from happening. We are continuing to work on our trainings. We have 2 that we are in the process of getting ready to record and hopefully have available for individuals and provide continuing education for those as well, which is always a plus for everybody to be able to get those. We have 2 more that are almost complete and ready to submit for review. And as soon as I get a hold of the person who's holding that up, I will deal with them. It's me. But we're hoping to be very close to being done with that, and we'll hopefully have a bench card as well for the training related to KRS 202B. And you may have noticed, referenced earlier in the commitment work group, they're doing some work on the 202A and 202B forms that will also be helpful to go along with that training. And that's all.
Are there any questions for the IDD work group? And if there is none, I will just comment that the Treatment and Access Committee is once yet blessed to have Crystal Adams as a power horse lead over this group. Just to comment, this group did not get just the first approved training from the Kentucky Judicial Commission on Mental Health. Sounds like they have now 1 and 2 and are working on 3 and 4. So, all right, keep up the good work. We'll next turn to the court responses work group. And due to her docket, Judge Burke is also appearing online. So we can allow her to tell what's going on with the court responses work group.
Good afternoon. Hi, Kevin.
Hello.
The Court Responses Work Group has continued to discuss and explore legislative recommendations for the 25 session of the General Assembly. Most of those have centered on potential amendments to 202A and to concerns of the health and well-being of hospitalized minors. We have made some recommendations to the Executive Committee, and we consider to weigh those options. The group has also heard from the Department for Behavioral Health on the statewide expansion of AOT. After the significant allocation of funds for statewide expansion, we heard from Tara Brewer about how those programs were being implemented in different regions, and also how the University of Kentucky is starting to weigh outcomes in the programs that have already been implemented. And those outcomes are quite impressive to date. So it's really exciting to see how that is coming to fruition. And also, most recently, we heard from AOC and the Department of Specialty Courts on the expansion of mental health courts and the mental health diversion initiative and the creation of the behavioral health liaison position, which will be implemented in the different regions across Kentucky. That position is going to act as a support for all the statewide specialty programs in each region, and will offer advocacy and coordination and education and support to all those programs in the various regions. We're very excited to see that many of those positions have already been filled, and as they continue to fill those, we think there will be a more seamless approach among the court system as people are coming in, both pretrial, those who are a lower and moderate risk but have high need will be able to go through a diversion program, but then those who are a high risk, high need would go into specialty court programs under the current model, and hopefully we'll be able to reach more people through the design and the funding of these programs. One of the things that our group has agreed to do is be the advisory group for the Mental Health Diversion Initiative. And we have also agreed to take on the role of exploring concerns that have been raised to the Commission about barriers that families are facing when trying to seek petitions for Casey's Law. So I know some of you may have become aware of some of those issues that are raised, and a lot of times those issues are focused on or centered on the fact that it's difficult for families to find people who will do the evaluations. So we have agreed to explore and take on that issue in our committee. So that's all.
Any questions of Judge Burke and her work group? All right. And I know Judge Burke has been very passionate about these issues and a true champion for these causes over the years. So with that, I'll turn it over to Wes Butler, who is the lead on the Strengthening Community Response Work Group. Wes?
Good afternoon. The Strengthening Communities Work Group has met twice since the commission last met. In July, we went through our work plan and discussed legislative recommendations. There was one issue that kind of bubbled to the surface and had probably the most robust discussion about receiving substance use disorder mental health assessments while incarcerated. There was a recognition that there was a lot of data that incarceration can actually facilitate relapses upon reentry into the community. And there was a discussion about how maybe to bridge that gap. We just started that discussion, and I think we've invited the Jailers Association to come and speak with our work group at some point in the future. But that was one topic that I can see that we may be returning to on a pretty regular basis over the next few meetings or so. In August, we also met, and Medicaid's just been a wonderful partner with our work group, often coming in and speaking with our group about a variety of topics, of course, with the community aspect of what we do. Funding and making sure that the resources are there is a critical component. So we actually had 3 separate presentations, one on peer support billing services, one on jail service billing, and then school-based services. As you can see, our work group tends to focus on identifying particular needs in education and for the justice-involved individuals. So those are going to be topics that we will continue to come back on a pretty regular basis. Our next meeting is Friday, September 27th at 10 a.m. And I'll close with 3 quick thank yous. First and foremost, Shauna, Jennifer, Maria, you've kept our work group going smoothly and efficiently, and so grateful. Also want to thank Medicaid again. Been a wonderful partner. And then finally, a thank you to Justice Lambert and to Shauna for presenting to, excuse me, to a large group of healthcare attorneys about the work of the commission. So it was wonderful to have you, and I appreciate you doing that. That's all I have.
Thank you, everyone. I know we've gone a little bit over time, so I won't belabor you with 15 minutes of closing remarks, it looks like, on the agenda. Just one quick word. September is Suicide Prevention Month. Every time I'm speaking lately, I'm reminding people to not use the blame phrase, commit suicide. We want to delete that shaming language and stigmatized language from our day-to-day discussions. And use a phrase such as died by suicide. And hopefully that will go some distance into helping reduce stigma relating to mental health and those in crisis. Also, of course, our next meeting is December 5th, and Shauna says, take some cake home with you or hang around here and eat your cake for a few minutes. Thank you all for a very uplifting meeting of good news.